Okay, so now we're going to talk about heart failure, hypertension, and dysrhythmias. Heart failure occurs when the heart is unable to pump the blood adequately through the body. This can either happen on the left side of the heart or the right side of the heart. If it happens on the left side of the heart, it can either be diastolic or systolic. Diastolic happens when the heart muscle gets thick and stiff and it's unable to pump because it's so big and it can't contract down all the way. If it's systolic, the heart muscle is actually thin and weak, so kind of like a thin, wimpy muscle. It just can't do its job. If it's the right side heart, if there's right-sided heart failure, this happens when the heart, this occurs when the heart is unable to pump against the increased pressure in the pulmonary circulation. So with left-sided heart failure, the blood will back up into the lungs. With right-sided heart failure, the blood backs up into the body. So left lungs, don't know how I would do this, but right body, I guess that could show you. I don't know, but just think left lungs, because the left side of the heart is getting blood from the lungs, so that if it backs up, it's going to back up into the lungs. The right side of the heart is getting blood from the body, so it's going to back up into the body. So there are different symptoms that come along with left-sided and right-sided heart failure. With left-sided heart failure, a patient's going to have dyspnea, orthopnea. They're going to have pulmonary crackles. They could have a cough that has like a frothy sputum. Things that are issues with their lungs. Remember, the blood is backing up into the lungs. With right-sided heart failure, this patient's going to experience edema. So it could be in their legs, their genitals, their lower trunk. They could have edema in their liver, their abdomen, which would be ascites. They could have a jugular vein distension. This edema can also be pitting edema, so that if you like press into it, instead of it springing back instantly like that, think of it just being like an indentation that's pitting and leaves a little pit in their skin. That's pitting edema. With patients who have heart failure, they are going to have a decreased blood pressure. They're going to also experience fatigue and confusion. So the different types of heart failure, we talked about left-sided and right-sided, or I guess this is my left hand and this is my right hand. So left-sided heart failure backs up into the lungs, right-sided heart failure backs up into the body. So for these patients, when you're assessing them, you're going to want to weigh these patients, especially the right-sided heart failure patients, because if they have like a very large increase of fluid in their body, they can go into fluid overload. But so the part of the assessment is that you need to weigh these patients. And you need to also do an EKG for patients who are taking Lasix or ACE inhibitors. And you need to watch out for digoxin toxicity, because they may be taking digoxin. You don't want it to get to a toxic level. So for evaluation, you're testing their digoxin levels. You're doing ABGs on them. You're checking their potassium and their sodium levels. You're looking at their BNP. If it's an increased level, it could be more severe. And you're also doing an ECG on these patients. For these patients, there's different drugs that you can take to help get the fluid off of their body, especially if they are right-sided heart failure. They can take nitrates to help decrease their blood pressure. They can take Lasix, which would be like different diuretics, to help decrease the fluid in their body. They can have ACE inhibitors, which will help increase vasodilation. Digoxin will decrease their heart rate while increasing contractility of the heart. Nesratide, which would be given IV, is something that you're going to want to monitor their blood pressure with, and you can give them morphine for anxiety. But the overall goal is to decrease the fluids in their body and decrease the sodium in their body. So you're going to do that by giving them different drugs to help rid that extra fluid and rid that sodium that's in their body. You can also give them beta blockers. This would be specifically for patients who have a chronic heart failure. Again, we were talking about nursing diagnosis. These patients are going to have excess fluid volume, so fluid volume overload. They could have impaired gas exchange, especially if they have left-sided heart failure, because they have all that extra blood backing up into their lungs. They could have anxiety, which would be because they're fearful and afraid of suffocating, especially if they have left-sided heart failure. For these patients, I'm going to just show you this real quick. So we talked about left and right-sided heart failure. We talked about their symptoms for left and right, weighing the patient. These are the different drugs that you can give. It's all about decreasing the fluid in their body and decreasing the sodium. For teaching and planning things for your patient, you can give them Tylenol for headache from the nitroglycerin that they could be taking. You're going to monitor their potassium, especially with their Lasix administration, like if they take Lasix, because it can cause them to be hypokalemic, and if they take an ACE inhibitor, it could cause them to be hyperkalemic. You decrease their fluid intake, so like a strict INO situation, and you want to instruct your patients to call the doctor if they experience a weight gain of more than 2 pounds overnight, more than 5 pounds in a week, 5 pounds from their goal weight, or a decrease of 5 pounds from their goal weight. So ideally it's 2 pounds. If they gain more than 2 pounds in a day or 5 pounds from their goal weight, they need to call their doctor. There are some different nursing interventions that kind of go along with like a mnemonic device called Unload Fast. So I'll put this here for you and I'll explain what they are. I think that's in focus. I don't really know. Okay, the first one for Unload Fast is an upright position. This is going to prevent the pooling of the blood in their lungs and hopefully allow them to breathe easier. Give them nitrates to decrease their blood pressure. Give them Lasix to decrease the fluid in their body. So we have UNL. Now to the O is for oxygen. You want to increase the blood O2 level, obviously for them. A is for ACE inhibitors. This is going to increase vasodilation. D for digoxin. This is going to slow the heart rate and increase contractility. Now we're getting into fast. F is for fluids. You want to decrease it overall so it decreases the blood volume. You want to decrease the A afterload of the heart. You want a sodium, S, restriction, and T, just an overall different tests that you can do for your patient. So Unload Fast. That's for heart failure. For risk factors for heart failure, for left-sided heart failure, the patient may have hypertension, coronary artery disease, or a valvular disease. With right-sided heart failure, they may have left ventricular failure, a right MI, so a right myocardial infarction, pulmonary hypertension, COPD, acute respiratory distress syndrome, or ARDS. We talked about how a patient will have increased heart rate and increased respiratory rates when they have left-sided heart failure. They'll have decreased tissue perfusion. These are symptoms, not risk factors anymore, sorry. They'll have fatigue, angina, weak pulses, and dizziness. With right-sided heart failure, they'll have peripheral edema, so that overall like general swelling of their body. They may have an increased blood pressure if they have excess fluid, or a decreased blood pressure if they have just heart failure. We talked about their BNP, which is their B-type natriuretic peptide, and doing a urinalysis, which is looking at the protein and the high specific gravity of their urine. And yeah, so there's a lot of different things that go along with heart failure, but primarily remembering that left-sided heart failure is going to back up into the lungs. Right-sided heart failure is going to back up into the body. So if it backs up into the lungs, they could have a cough that's like with a frothy sputum. They could have pulmonary crackles. They could have, obviously they're going to have issues breathing if they have extra blood in their lungs. With right-sided heart failure, they're going to have edema. They could have, edema. They could have an enlarged liver or spleen with ascites. They could also have anorexia or nausea because of that extra fluid, like pushing on their abdomen, which is where their stomach is, obviously. They may also have polyuria. With right-sided heart failure, they will have weight gain because they have all that extra fluid. And we talked about different things that can cause the heart failure. Like with left-sided heart failure, the patient may have hypertension, coronary artery disease, or a valvular disease, while right-sided heart failure, the patient may have pulmonary hypertension, COPD, acute respiratory distress syndrome, the right-sided MI, myocardial infarction, or a left ventricular failure. So there's lots of different things that can cause heart failure, but overall, it's dealing with the heart not being able to pump adequately for the body. Going along with heart failure, hypertension can cause some types of heart failure. If it's pulmonary hypertension, it can cause right-sided heart failure. If it's general hypertension, it can cause left-sided heart failure. So now we're going to talk about hypertension. Hypertension is high blood pressure. There's nothing to diagnostically test it. It's not like you can go into a CBC and say, oh, this value is this, blah, blah, blah. That means they have hypertension. hypertension, it's defined by having 2 to 3 consecutive readings above 140/90. Now, these numbers can change depending on how old the patient is and if the patient has diabetes or another disease. But typically, if the patient is over 60 years old, it's 150/90. Under 60 is 140/90. And then if they have diabetes, it's 130/85. So I'll show you those numbers right here. So high blood pressure, it's having 2 to 3 consecutive readings higher than these numbers. Ideally, we want our patients to have lower than these numbers. So there are things that control the blood pressure in the body. It's the arterial baroreceptor system, like in the aorta, body fluid volume, so the amount of blood in the body, the RAAS system, and vascular autoregulation. There are different things that can increase the risk factors for a patient to get hypertension, and that includes their family history, hyperlipidemia, smoking if they're over the age of 60, if they consume excessive amounts of sodium, alcohol, or caffeine, if they are obese, if they are inactive, if they have low potassium, low calcium, or low magnesium levels, if they're under stress. And another hypertension risk factor is African Americans. So there's a greater prevalence of hypertension in African Americans. Symptoms of hypertension include blurred vision, headache, dyspnea, flushing, and dizziness, which they just kind of go along with it. If your blood pressure is really high, you're going to be all like, my head hurts, I'm dizzy, I need to sit down, I can't breathe. So there's 3 different types of hypertension. There's essential, secondary, and malignant. Now, malignant is severe. It is a medical emergency. It is classified a blood pressure greater than 200/150. So that's all you really need to know about that, but just know malignant is something severe, medical emergency, go to the hospital right now type of thing. Okay, so essential hypertension is not caused by an existing health problem. It's just as plain as could be. It's essentially hypertension. Secondary hypertension is with specific diseases or drugs. So like if a patient has kidney disease or Cushing's syndrome, if they have a brain tumor, if they're pregnant, or if they're taking certain types of drugs that could increase the blood pressure, that would be considered secondary hypertension. When you assess these patients, you're going to want to obviously ask them the gambit of different things that they could be doing, like what is your sodium normal intake? Do you drink coffee? Do you drink alcohol? Do you smoke? How active are you? What's your BMI? What's your family history? You're going to want to ask them if they've had any dizziness or fainting. You'll ask them about their lifestyle, if they're active or not. I think we already said that. The overall goal for these patients is obviously to bring the blood pressure down. So there's different drugs that can do that. You can either do it with a beta blocker, calcium channel blocker, ACE inhibitors, ARBs. I mean, even diuretics can work. There's a whole host of things. So if one drug doesn't work well for a patient, there could be another drug that works really well for a patient. Or if this drug has this side effect that the patient really doesn't like, then they could go to this drug. So there's a whole host of different drugs and different classes of drugs that doctors can prescribe for these patients that will control the blood pressure for them. Another thing is that you do want to teach lifestyle changes, so like decreasing sodium, decreasing their weight, decreasing alcohol consumption, decreasing stress, which is a lot easier said than done, obviously, smoking cessation, and stop drinking caffeine, or maybe lessen drinking their caffeine, but I mean, our book says to stop drinking caffeine, so good luck telling people to stop drinking their morning coffee. But I mean, there's a lot of things that go along with hypertension, but remember, those are the numbers for if they're over 60 years old, under 60, and then if they have diabetes. I hope this isn't blurry for you. And those are the different types of drugs that a patient could take to help control their blood pressure. Okay, the next thing we're going to talk about are dysrhythmias, and this is like an abnormal heartbeat. It's classified typically by the site of origin, whether it's ventricular, if it's sinus, it's atrial. We're not going to talk about those specifics, but they could say a ventricular dysrhythmia. Then the doctor knows, oh, it was in the ventricles or wherever. But a dysrhythmia is just an abnormal heartbeat. The risk factors for a dysrhythmia include myocardial infarction, electrical imbalances, especially potassium and magnesium. Potassium really deals with the heartbeat, so if somebody is hypo or hyperkalemic, then they could have dysrhythmias. Hypoxia can also cause dysrhythmias. Drug toxicity, hypovolemia, so low blood volume. If somebody uses like illegal drugs like cocaine or other like inhaled things, I don't know an inhalant, but something that somebody could inhale that can cause a dysrhythmia. And if somebody uses nicotine or alcohol excessively, that can also cause dysrhythmias. There's different types of dysrhythmias. If they could have a bradycardia, Brady dysrhythmia, which would be a low dysrhythmia, so less than 60 beats per minute, or a tachydysrhythmia, I think I said that right, which is over 100 beats per minute. They can also have premature complexes, and this happens when the cardiac cells fire the impulse before the next impulse is produced. So that could be like a palpitation. So like Brady dysrhythmia is low, tachydysrhythmia is high, and then just premature complexes, the impulse is going prematurely. The symptoms for a dysrhythmia are kind of similar to some heart failure and some hypertension things, just things that are generally affecting the heart. So like chest discomfort that's radiating towards like the jaw or to the back or to the arm, restlessness and anxiety, nervousness, confusion, dizziness and syncope being fainting, tachypnea, which is an increase in respirations, pulmonary crackles, hypotension, weakness and fatigue, pale, cool skin, and diaphoresis, being like excessive sweating, delayed capillary refill. Can't even do it correctly right now. They could have a jugular vein distension. They could have nausea and vomiting. These patients will have decreased urine output. They could also exhibit S3 or S4 heart sounds, and they may be short of breath. When you're assessing a patient that has a dysrhythmia, or you're thinking they have a dysrhythmia, you need to take their apical pulse because there may be a pulse deficit compared to the other pulses on their extremities. So like take their apical pulse, take their radial pulse at least for a minute so you can get a full count. You also need to monitor their cardiac enzymes and their electrolytes. Remember, especially potassium and magnesium. You need to monitor them for any chest pain and have them describe it and rate it, and I guess time it if you want to, and any respiratory difficulty. The drugs to treat dysrhythmias are obviously called antidysrhythmics, and the planning and like different goals for the patients. The patient may have a long-term thing where they could have a pacemaker implanted, which is going to help fix the electrical current of the heart. So for those patients, you want to teach them to like avoid magnets and avoid cell phones 6 inches away from the heart, like from where the pacemaker is implanted, and to carry an identification card. So it's kind of some random things about antidysrhythmics. This is a little card I got from the hospital about antiarrhythmic, which is very similar to a dysrhythmia. It's an arrhythmia. So those are some antiarrhythmia drugs. Let me see if I have one for antidysrhythmia. I don't think I do. But it would be the same kind of drug. It's just trying to fix the electrical current in the heart. So that's all we have for heart failure, dysrhythmias, and hypertension. I hope this helps. Who knows?